3 pills in the morning, 2 more at night. There used to be one. You can remember the first one. The doctor wrote it on a pad, tore the page, and said, "This will bring the numbers down." That was years ago. You could not tell someone what month it was, but you remember the pen, blue ink. Now there are 5, and you cannot quite remember when the 5th one got added. Nobody sat you down for that conversation. It just appeared on the pharmacy label one quarter, and you started taking it like the rest. Orange bottle, white cap, same shelf next to the toaster. Right now, somewhere behind those bottles, one organ in your body is aging faster than the rest of you. 10 times faster if certain patterns go unchecked. You cannot feel it happening. Your doctor is not testing for it. And the thing accelerating that damage is sitting on your kitchen counter right now, lined up in a row you could arrange with your eyes closed. This is not about blood pressure, not today. Today is about your kidneys. Today is about your kidneys. What happens to kidney filtration after age 60 when certain blood pressure medications push at full force for years? And nobody checks what those pills are doing to the organ that cleans your blood. Nearly 1 in 3 adults over 60 on blood pressure medication shows signs of kidney function decline that may not be aging at all. Some of it is. But some of it is the medication itself doing exactly what it was designed to do, just in an organ nobody is watching. And the part that is medication never gets discussed in a 15-minute appointment, where blood pressure is the only number on the table. Over the next hour, I am going to walk you through 5 specific blood pressure medication patterns that nephrologists flag in patients over 60. You will see the blood panel your doctor probably has not ordered in years, the one that shows what is actually happening below the numbers. I will give you the exact question to ask at your next appointment, word for word. You will not have to figure out how to phrase it. You will see the one morning routine swap that can reduce medication load while protecting filtration. And at the end, I will hand you a medication review checklist you can bring to your next visit. Put it directly in your doctor's hands. None of this costs anything. None of this means stopping your medication tonight, and none of this requires a new doctor. But before any of that, I need to tell you something about the way blood pressure has been managed for the last 20 years. It will change how you look at those bottles tomorrow morning. You take the morning pills with water, maybe orange juice, maybe coffee that has gone slightly cold while you were letting the dog out or checking on something in the other room. The bottles are lined up on the counter, always in the same order. You know the sequence by now, the white oval one first, then the small round one, then the one you cut in half because the pharmacy sends it in the wrong dose. You have been meaning to call about that for 6 months. It takes about 45 seconds. You do not think about it anymore. It is like brushing your teeth, something your hands do while your mind is somewhere else. The numbers come down, the doctor says good, and you move on with your Tuesday. And that system has worked. It really has. For years, those pills have kept your readings in a range that satisfies the chart on the wall. The numbers are stable, the appointments are short. The doctor flips through the file, nods, maybe glances at the screen, and says, "Whatever you're doing, keep doing it." Your spouse has stopped worrying. Your kids have stopped asking about it at dinner. The blood pressure is handled. One less thing on the list. You have done everything a responsible person does. You took the medication on time. You showed up to every appointment. You did not argue when they added the second pill, or the third, or when the dose got bumped up because the reading in the office came in a little high. Even though your home readings were fine every other day that month, you did what you were supposed to do, and still, there is a number buried on your blood panel that has been drifting, not fast, not in a way that triggers a phone call from the nurse, but drifting. It is called your GFR, glomerular filtration rate. In plain terms, it measures how well your kidneys are cleaning your blood right now compared to how well they should be. In most adults over 60 on long-term blood pressure medication, this number has been sliding downward for years, quietly, without anyone mentioning it. At your last visit, when the doctor glanced at the printout and said everything looks fine, that number was on the page. It just was not circled. Your blood pressure was 128/78. The doctor said good. So the question you are sitting with right now is not whether your blood pressure is controlled. It is. The question is what the cost of that control has been. What has been happening to the organ that filters every drop of blood in your body every day? The medication forces pressure down by a method your kidneys were never built to handle at this age and this dose. Not for this many years running. That is what the next hour answers. Not with fear, not by blaming your doctor for anything, with 5 patterns, 5 tests, and 1 conversation that turns you into the person who reads the whole blood panel, not just the top number. Some of you are on 1 blood pressure pill. It was prescribed years ago. The number came down and nobody discussed it again. You refill it every 90 days like clockwork. You are here because someone you trust sent this your way, or because something about the image on the screen made you pause mid-scroll. A picture of 2 kidneys, 1 healthy and 1 that looked older than it should. You are the steady one. You take your medication and keep your appointments. The question you have never asked at the pharmacy counter is whether a pill that worked at 55 still makes sense at 68. Whether the dose that fit your body 12 years ago fits the body you have now. Some of you are on 3 or 4, maybe 5. Each one was added after a reading that came in higher than the last. Usually at the doctor's office, usually on a day when you were already running late and anxious about the appointment itself. You have a small pharmacy's worth of bottles on your kitchen counter, and you have noticed something you do not bring up at appointments. You're more tired than you used to be, more dizzy when you stand up from a chair. You wake up 2 or 3 times a night to use the bathroom. You mentioned it once. Your doctor said that is normal for your age. You are the stacker. And the question you carry quietly is whether the pills are still solving the original problem, or whether they are managing each other's side effects in a circle nobody is tracking. And some of you are here because something already happened. A number crept up on a blood test. A word got mentioned in a visit that used to be about blood pressure and is suddenly about something else. Creatinine, GFR, the phrase, keep an eye on it, which is doctor language for something is changing and we are not sure why yet. You are the one who noticed. And underneath the medical terminology and the scheduled recheck, the real question is whether you caught it in time. All 3 of you end up in the same place. Someone finally explains what blood pressure medication does to your kidneys over time, why nobody connected the dots for you, and what you can do about it starting this week. Not next month, not after another appointment, this week. I want to take you to 2 places. They are both 6 weeks from now. They are both real, and they are both waiting for you on the other side of the next hour. The first is your doctor's office. You walk in carrying a single sheet of paper, not a printout from the internet, not a stack of articles with highlighted sections that make the receptionist nervous. 1 sheet. On it, 4 blood tests listed by name and 1 question written out in your own handwriting. The nurse takes your blood pressure. Normal routine. The doctor walks in, pulls up the chart, and opens their mouth to say the usual thing about the numbers looking fine. Before they finish, you hand them the paper. The doctor's face changes. Not because you have done something wrong, not because you are challenging them, because you have asked for something specific that they should have been ordering every 6 months for the last several years, and they know it. They read the list, they look at the paper, they look at you. And for the first time in a long time, the appointment is not 15 minutes of confirming that nothing has changed. It is a conversation, the kind where your doctor leans forward slightly and starts explaining things they assumed you did not want to hear, the appointment you should have been getting for the last 5 years. You walk out 11 minutes later with 2 lab orders in your hand and an appointment in 3 weeks to go over the results. The receptionist looks at you differently on the way out. Not because you scared anyone, because the doctor walked you to the door, which has not happened in years. You asked a question they respected, and the question came from a place they did not expect. The second place is your daughter's kitchen table on a Sunday afternoon, or your neighbor's porch after church, or your son's living room while the grandkids are playing in the next room. Someone mentions that their father just got his blood pressure medication increased again. 3rd time this year. He is dizzy all the time. His ankles swell by evening. He told his doctor, and the doctor added another pill. You listen. You let them finish. And then you say something you could not have said before today. You say, before they add anything else, ask them to check his GFR and his electrolytes. You do not say it like someone who read it on the internet. You say it like someone who has seen the pattern, calmly, with the weight of understanding behind it, not the urgency of panic. And the person across from you gets quiet for a moment. They look at you the way people look at someone who just changed the shape of a conversation. Then they reach for their phone to write it down. You did not need a medical degree to say that. You just needed to know what to look for. That is what the next hour builds inside you. A way of seeing. The kind that turns you from a patient into a person who notices things about their own body that the system was never designed to catch. Graham Kettering was 67 years old, retired machinist from Akron, Ohio. Hands like worn leather gloves from 30 years of holding steel. He showed up 10 minutes early to everything, doctor's appointments included. He scheduled the same Tuesday every quarter and never missed. Graham kept a small spiral notebook on the kitchen table. Right next to the salt shaker his wife Margaret had quietly moved to the back of the counter 3 years earlier. Every morning at 6:15, before the coffee finished, he sat in the same chair and strapped on the cuff his daughter bought him at Walgreens. 2 numbers, written in pencil. He had been doing this for 11 years. The notebook was almost full. He was proud of that notebook. His numbers were beautiful. That is the exact word his cardiologist used at the checkup in March. Beautiful. 126/76. Consistent. Textbook. Graham was on 2 medications, lisinopril and hydrochlorothiazide, and he had not missed a single dose in over a decade. He brought the notebook to every visit. The doctor would flip through it, nod the way a teacher nods at good homework, and say, "Whatever you are doing, keep doing it." Graham was doing everything right. By every measure anyone was tracking, he was the model patient. Here is what the notebook did not track. 4 years before that March appointment, Graham's GFR was 88. That is a healthy number. Strong filtration. The kidneys are working the way they should. 2 years later, it drifted to 71. Still within the range the chart on the wall calls normal for a man his age. Nobody mentioned it. Nobody circled it. Last March, on the same day the doctor called his blood pressure beautiful, Graham's GFR had dropped to 54. That number means stage 3A kidney disease. It was printed on the 3rd line from the bottom of the lab report. The doctor did not circle it, did not bring it up, said everything looks good, see you in 3 months. I need you to understand what happened inside Graham's body, because this is where the whole picture changes. Think about the water filter under your kitchen sink. You have seen one. Maybe you have changed one. Every day, blood flows through your kidneys the same way water flows through that filter. The filter catches what should not pass through: waste, excess fluid, toxins your body is finished with. It lets the clean fluid continue. When the filter is new and the water pressure is right, the system works perfectly, quietly, for years. You never think about it. Now here is what happens when you increase the water pressure. Not by a little, by a lot, and not for a day, for a decade. The mesh inside the filter starts to stretch. The tiny openings that were designed to catch waste begin to widen. At first you notice nothing because the water coming out still looks clean. The output looks normal, but the mesh is degrading from the inside, fiber by fiber. And by the time the water quality drops enough for you to notice it in your glass, the filter is too far gone. Turning the pressure back down will not fix it. That is what was happening to Graham Kettering for 11 years. His blood pressure was controlled. The notebook proved it every morning at 6:15. But the way the medication achieved that control was the problem. Hydrochlorothiazide, the diuretic in his second pill, was pulling fluid out of his body so aggressively that his kidneys had to work overtime to concentrate what remained. That is what diuretics do. They lower the volume to lower the pressure. Imagine draining half the water from the pipes in your house and expecting the filter to work normally. The kidneys bear the cost of that reduction, day after day. No rest day, no adjustment period. Lisinopril at his dose was lowering the pressure in the bloodstream. But it was quietly altering the pressure balance inside the kidney, the ratio between what flows in and what flows out of the filter mesh. The incoming pressure dropped. The outgoing pressure did not drop the same amount. The mesh caught the difference. The filter was stretching, the mesh was widening, and nobody checked the filter, not once in 11 years. Graham did everything right. He took the pills, he tracked the numbers, he showed up on the same Tuesday every quarter, and his kidneys declined anyway. Not because he failed, not because he was careless, because the thing being measured was never the thing that mattered. A blood pressure cuff reads the pressure in the pipe. It does not read the condition of the filter. And for 11 years, everyone was staring at the pipe. This is the first medication pattern. High-dose diuretics combined with ACE inhibitors in adults over 60, running for years without regular kidney function monitoring. It is the single most common blood pressure medication combination prescribed in the United States. And it is the first combination a nephrologist would flag if they opened Graham's chart. Graham found out about his kidneys 5 months after the beautiful reading. His legs started swelling in August, the kind of swelling that leaves a dent when you press your thumb into the shin and hold it for 3 seconds. By September, he was sitting in a chair across from a kidney specialist who asked him a question nobody had asked in 11 years. How long have you been on hydrochlorothiazide? Graham said 11 years. The specialist closed the folder, looked at the wall for a moment before speaking, and the conversation that followed was no longer about prevention. It was about managing what was already stage 3. The specialist asked why nobody had been monitoring kidney function. Graham did not have an answer. He had been going to the same doctor for 15 years. He brought the notebook every time. The spiral notebook is still on the kitchen table. The numbers inside it are still beautiful. They were always beautiful. That was never the problem. Now I want to show you something that happened in Florida in 2019 that will change the way you think about the next 2 pills on your counter. A team at a university hospital in Central Florida pulled records on 4,200 adults over 65. All had been admitted to the emergency room for acute kidney injury, not the slow, creeping kind that Graham experienced over a decade. The sudden kind. Something hit their kidneys hard enough to put them in a hospital bed within hours. The researchers expected to find the usual suspects: dehydration from the Florida heat, urinary infections, maybe contrast dye from a CT scan that pushed already weakened kidneys past a breaking point. What they found instead was something nobody on the team had predicted. Over 40% of those acute kidney admissions shared a single medication on their chart, a thiazide diuretic, most commonly hydrochlorothiazide, the same pill Graham had been taking, prescribed for blood pressure, and every one of those patients had been on it for more than 3 years. No electrolyte panel ordered in the last 12 months. Their potassium was low, their magnesium was low, their sodium had drifted into a range that left their kidneys operating in a state of chronic, low-grade mineral starvation. Not for days, for months, sometimes longer. The acute event, the one that landed them in the ER, was just the moment the slow damage became visible. Here's the part that should make you sit forward in your chair. Those 4,200 patients were not skipping doses. They were not eating fast food 3 meals a day or ignoring their doctors. They were compliant. They were doing everything they were told to do. The diuretic was performing exactly as designed. It was pulling sodium and water out of the bloodstream to lower the pressure reading on the cuff, but it was pulling potassium and magnesium out with it. And nobody was measuring what it took. Nobody was replacing what was lost. Nobody ordered the $30 blood test that would have shown the mineral tank was running dry. Remember the water filter. It does not just need the right pressure to work. It needs the right mineral balance in the water flowing through it. When you strip the minerals, the mesh gets brittle. It loses the flexibility that lets it expand and contract with each pulse of blood. And then one hot August afternoon, one glass of water that got skipped, one long car ride without a rest stop, the brittle mesh cracks. That is what happened in those Florida ERs. 4,000 people with perfectly controlled blood pressure, doctors who said everything looks good, kidneys quietly starving for the minerals the medication was designed to remove. The youngest was 66. The oldest was 89. The average time on medication before the event was 6.5 years. 6.5 years of the filter running dry while the pipe pressure looked perfect. The second pattern is furosemide. You may know it by the brand name Lasix. This is the stronger diuretic, the one prescribed when hydrochlorothiazide alone cannot push the numbers down far enough. Furosemide is a sledgehammer where hydrochlorothiazide is a mallet. It forces fluid out of the body so fast that kidney perfusion drops within hours of a single dose. Kidney perfusion means the amount of blood actually reaching the filter mesh. In a younger patient with strong kidneys, the body compensates. In an adult over 60 whose filter is already working at reduced capacity, furosemide at standard doses does the job on blood pressure. But it does it by running the filter at its structural limit every single day. In the Florida data, patients on furosemide had twice the rate of acute kidney events compared to patients on hydrochlorothiazide alone. Twice. Same age range, same blood pressure targets, same level of compliance. The only difference was the force of the flush through the filter. And the third pattern is the one that surprised even the researchers who designed the study: amlodipine, the calcium channel blocker. It is one of the most widely prescribed blood pressure medications on the planet, and most patients think of it as the gentle one. No fluid loss, no dizzy spells when standing up. It relaxes the blood vessels. The side effect profile looks clean. It feels safe. But here is what amlodipine does inside the kidney that nobody explains at the pharmacy counter. It dilates the artery going into the filter, not the artery going out. When the entrance opens wider but the exit stays the same size, more blood rushes through the mesh at higher velocity. And here's what makes this pattern so dangerous to catch. The GFR number on your blood panel, the one that measures how well the filter is working, actually looks stable. It may even improve slightly because more fluid is being pushed through per minute. The output looks great. The mesh is tearing under the pressure. Nephrologists have a name for this: hyperfiltration. It is the kidney equivalent of a retail store reporting record sales while the foundation underneath the building is cracking. The revenue looks fantastic. The numbers are up. Nobody inspects the foundation because the revenue numbers say everything is fine. This is why I told you in the first story that the thing being measured was never the thing that mattered. The blood pressure cuff measures one number. The GFR measures another. And amlodipine can make the GFR look reassuring while the kidney is being overworked from the inside, day after day, at a pace the mesh was never designed to sustain. A patient can be on amlodipine for 8 years and show stable kidney numbers the entire time. Then one dehydration, one fever, one surgery. The kidneys collapse in a way that looks sudden. It was building quietly for a decade. 3 patterns now: diuretics stripping minerals from the filter until it turns brittle, furosemide forcing the flush so hard the mesh hits its structural ceiling, amlodipine masking the damage behind a filtration number that looks stable or even good. And in every case, in Graham's kitchen and in those Florida emergency rooms, the patients had blood pressure readings their doctors called controlled. There is a question forming underneath all of this. You can feel it. Who designed the system that checks the pipe and never checks the filter? Who decided blood pressure was the finish line and kidney function was a footnote on page 3 of a lab report? That question has a specific answer. It has a year, it has a committee, and it has a decision that changed how every doctor in America prescribes blood pressure medication to adults over 60. That is what comes next. And when you hear it, you will understand why every doctor in your life has been watching one number and ignoring another. Not because they are bad at their job, because the job was defined wrong. In 2017, a committee sat down in a conference room and changed one number. That number changed how every doctor in America treats blood pressure in adults your age, and not one person on that committee was a nephrologist. The American College of Cardiology and the American Heart Association released new blood pressure guidelines that year. The old threshold for high blood pressure was 140/90. It had been 140/90 for decades. Doctors were trained on it. Patients knew it. The number felt permanent. The new threshold was 130/80, 10 points lower. Sounds like a rounding error. It was not. Overnight, 30 million Americans who went to bed with normal blood pressure woke up with a diagnosis. 30 million new candidates for medication. Some were already on pills and now needed higher doses. Some had never taken a blood pressure pill in their lives and were suddenly holding a prescription at the pharmacy counter. And the doctors who prescribed these medications were not guessing. They were following the updated protocol, the one published by the most respected cardiology organizations in the country, the one that every medical board, every insurance panel, and every hospital system would use to evaluate their performance. Here is what the protocol optimized for: cardiovascular events, heart attacks, strokes. The committee reviewed a large trial called SPRINT. They concluded that pushing blood pressure below 130 reduced cardiac events in a meaningful way. And they were right. The cardiac event data improved. Fewer heart attacks in the treatment group, fewer strokes. The numbers supported the change. Here's what the protocol did not optimize for: kidneys. The SPRINT trial itself showed a signal that should have slowed things down. Patients in the aggressive treatment group, the ones pushed below 130, had a higher rate of acute kidney injury than the standard treatment group. The data was there. It was published. The committee noted it in the supplemental tables. They acknowledged the kidney signal in the fine print. And then the guidelines went forward without a recommendation to monitor kidney function before escalating medication doses. They did not flag patients over 60 as a population that handles these drugs differently. They did not say, check the filter before you turn up the pressure. They said lower the number, and every doctor in America heard that message clearly, because that is how medicine works. The guidelines lead, the doctors follow, and the doctors followed because they are good doctors doing what the system asked. The fourth medication pattern comes directly from this guideline shift: atenolol, a beta blocker prescribed for blood pressure since the 1970s. For younger patients with strong hearts and strong kidneys, atenolol works fine. For adults over 60, atenolol reduces cardiac output. That means the heart pumps less blood per beat, and less blood per beat means less blood reaching the kidneys every minute. Think about the water filter again. You already know what happens when you increase the pressure too much. The mesh stretches. But there is a second way to damage a filter that nobody talks about. Reduce the flow. Turn the water pressure so low that barely anything moves through the mesh. The waste that should be flushed out builds up instead. The mesh dries between pulses. The filter cannot clean itself because there is not enough water moving through it to carry the waste away. Atenolol does not push the filter too hard. It starves it. In 2004, a major study published in The Lancet concluded that atenolol was no better than a placebo at preventing strokes in elderly patients. The study was clear. The authors recommended replacing atenolol with newer alternatives that offered the same blood pressure reduction without starving the kidneys. That was 22 years ago. Atenolol remains one of the most commonly prescribed beta blockers in the United States for adults over 60. 22 years after the study said, stop using it in this population. The guidelines were slow to remove it. Many doctors never updated the prescription because the patient was stable. The blood pressure was controlled. The appointments were short. Nobody wanted to change something that appeared to be working. The pipe pressure looked fine. The filter was drying out underneath. And the protocol said, hold course. The fifth pattern is the one that ties all five together. It is not a new pill. It is an old pill at the wrong dose, lisinopril. You already met it in Graham's story. At moderate doses, lisinopril is one of the most kidney-friendly blood pressure medications that exists. Nephrologists prescribe it specifically to protect filtration. It relaxes the outgoing artery of the kidney, reducing the pressure on the filter mesh. At 10 milligrams in most adults, it is protective. It is good medicine. It is the pill a nephrologist would want you on if you had to choose one. But the 2017 guidelines pushed doctors to get that number below 130. And when 10 milligrams did not bring the number down far enough, the dose went to 20, then 40. In some patients, higher. At 40 milligrams in a 71-year-old whose GFR is already in decline, the math changes. The outgoing artery constricts too far. The pressure balance inside the kidney flips. The filter, designed for moderate flow, gets squeezed from both directions. The same drug that protects kidneys at one dose becomes the fifth pattern at another. And here's the part that should sit with you for a while. Your doctor probably prescribed every one of these 5 medications for a legitimate reason. The blood pressure was too high. The risk was real. The guidelines said treat aggressively. The pills brought the numbers down. And at the time, at the dose, for the age you were when the prescription was written, every one of those decisions made medical sense. The problem was never your doctor's judgment. It was the system's blind spot. Nobody told anyone to go back and check the kidneys while the cardiovascular numbers improved. The doctor did not. The pharmacist did not. The nurse did not. The committee that wrote the rules did not. There was no reminder built into the system. No automatic flag at 3 years on a diuretic that said time to check the filter. No alert at age 65 that said this patient's kidneys now metabolize this drug differently than they did at 55. The system does not have that checkpoint. It was never built. The doctor is not the villain in this story. The doctor is the person who followed a protocol written by a cardiology committee for a cardiovascular outcome. They treated the heart, they watched the pipe, They did it well. And the protocol never once said, turn around and look at the filter. That is not a doctor failing. That is not a doctor being careless or lazy or negligent. That is a system built with a blind spot the size of both your kidneys. A system that asks your doctor to track one number and assumes everything else will be fine. Your doctor is doing what they were trained to do. The training has a hole in it. And you, right now, sitting here, see the hole. That is what changed, not your opinion of your doctor, your understanding of the system your doctor works inside. I want to tell you about Doreen Albright, because everything you have heard so far has been about the problem. Graham's kidneys declining, the Florida data, the guidelines that never looked at the filter. And if I left you here, in the middle of all that weight, you would walk away scared. Scared does not change anything. Scared makes people close the laptop and go back to taking the pills without asking questions. Doreen is the part that changes things. She is 71 years old, retired dental hygienist from Portland, Oregon, the kind of woman who flosses twice a day and will tell you about it whether you asked or not. She has a tabby cat named Ernie who sits on the kitchen table while she eats breakfast. Doreen had been on hydrochlorothiazide for 9 years and amlodipine for 4, 2 of the 5 medications you now understand differently than you did 40 minutes ago. Her blood pressure was well controlled, 124/74. Her doctor was pleased every visit. Doreen was not. She was tired all the time, the kind of tired where you sit down to put on your shoes and forget why you are putting them on. She was dizzy when she stood up from the kitchen chair, especially in the morning before breakfast, and she was waking up 3 times a night to use the bathroom. Ernie woke up 3 times too and started sleeping on the couch instead. She told her doctor about the fatigue and the dizziness. He said, "That is normal for your age." She told him again 6 months later. Same answer, same 15-minute appointment, same nod at the blood pressure number. In October, Doreen's daughter sent her a video, not this one, a different one. Something about kidney numbers and blood pressure medication. Doreen watched it on her tablet at the kitchen table on a Thursday evening while Ernie sat on the placemat. The next morning, she called her doctor's office and asked for her most recent blood panel results. She had never asked for that before. The receptionist paused before saying she would email them. Doreen sat at the kitchen table with a pen and a magnifying glass. She scrolled through the PDF until she found the line that said GFR. It read 58. She did not know what the number meant. She looked it up on her tablet. She found out that 58 meant early stage 3A kidney decline. That number had been printed on every blood panel she received for the last 2 years. It was always there. Nobody mentioned it. Nobody circled it. Nobody said anything. The following Tuesday, Doreen walked into her doctor's office without an appointment. The receptionist said there might be a wait. Doreen said that was fine. She sat in the blue chair near the window for 40 minutes. When the doctor came out between patients, Doreen stood up and said one sentence. "Can we look at whether my blood pressure medication is affecting my kidneys?" That is the question, word for word. The one I promised you at the beginning of this hour. Write it down if you need to. Say it in front of a mirror if that helps. It does not accuse. It does not diagnose. It does not demand. It invites the doctor to look at something they have not been looking at. And because it is framed as a question rather than a challenge, it lands differently than a printout from the internet. The doctor paused. He had his hand on the mouse, ready to click to the next screen. He stopped, pulled up her chart, scrolled to the lab results from April, then January, then the previous September. He looked at the GFR numbers lined up in a column, 67, 63, 58, a clear downward line. And for the first time in 9 years of treating Doreen Albright, he connected that line to the medication. He did not get defensive. He did not say the medication was fine. He said, "Let me look at this more carefully. Come back Tuesday." Within 2 weeks, Doreen's doctor replaced hydrochlorothiazide with a lower dose ACE inhibitor that put less strain on her kidneys. The amlodipine stayed, but at a reduced dose, enough to manage the pressure without forcing the hyperfiltration pattern you learned about earlier. The filter got a break. The mesh stopped being pushed to its limit every morning. And Doreen, on her own, added something to her routine. Before she took her morning pills, She drank 16 ounces of water with a quarter teaspoon of magnesium citrate powder stirred in. She did this because she understood now that diuretics had been stripping magnesium from her body for 9 years. She understood that her kidneys needed that mineral to keep the mesh flexible. She bought the powder at the grocery store for $7. It lasted 2 months. By Wednesday, the dizziness was gone. Not reduced, gone. 4 days after the change. She slept through the night for the first time in 3 years. Ernie moved back to the bedroom. At her 6-week recheck, Doreen's blood pressure was 130/78, slightly higher than before. Still within the range her doctor considered acceptable. Her GFR was 61, up 3 points. 3 points in 6 weeks after 2 years of sliding downward with nobody watching. The doctor looked at the screen, looked at her, and said, "Whatever you changed, keep doing it." Doreen's kidneys did not heal overnight. They may never return to where they were 5 years ago. Some of that mesh does not grow back. But the decline stopped. The filter stopped stretching. The mesh had time to rest. And it started with one question at a Tuesday morning appointment that lasted 8 minutes longer than the usual 15. "I want you to do something right now. If you have a glass of water near you, take a sip. Just one. Feel the temperature of it." That is the beginning of what Doreen did. Water before pills, minerals before pressure. Give the filter what it needs before you ask it to work. You have been sitting with me for close to 50 minutes now, and something has changed in you that I want to name, because if I do not name it, you might not notice it happened. You are not watching this the way you were watching it at minute 5. At minute 5, you were curious, maybe a little worried. You were listening the way you listen to a news story about something that might affect you, one ear open, ready to move on if it did not land. That is not where you are anymore. Right now, you know something. You know that hydrochlorothiazide strips minerals from a filter that cannot replace them on its own. You know that furosemide forces the flush so hard the mesh hits its limit. You know that amlodipine masks the damage behind a number that looks stable. You know that atenolol starves the filter by reducing flow. And you know that lisinopril, a drug designed to protect kidneys, becomes dangerous at the wrong dose in the wrong patient at the wrong age. 5 medications, 5 patterns. You can name them, you could explain them to someone at dinner without reading from a page, but here is what changed that matters more than the names. You now look at a blood panel differently. The next time someone hands you a printout, your eyes are going to find the GFR line before you find the blood pressure line. You are going to read it the way a mechanic reads an oil pressure gauge, not as a number to glance past, as a signal. A signal that tells you whether the filter is holding or whether the mesh is starting to stretch. You are going to sit in a doctor's office and ask a question that changes the shape of the appointment. You will not be combative. You will not demand anything. You will hand them a sheet of paper or say a single sentence, and the conversation will shift from box checking to actual medicine, the kind where both people in the room are paying attention to the same thing for the first time. And there is a moment coming that you cannot schedule, but you will recognize when it arrives. Someone at dinner will mention their father's medication getting increased again, or their neighbor's swollen ankles, or their own dizziness every morning, and you will feel something rise in your chest. Not alarm, recognition. You will see the pattern in someone else's story, the way you now see it in your own. And you will say something. Not a lecture, a quiet sentence, the right one, the one that makes the other person stop chewing and look at you differently. That moment will not feel dramatic. It will feel ordinary. You will say it like you have known it for years. That is how identity works. It does not announce itself. It just becomes the way you see. There will be another moment after that one. You will be at the pharmacy picking up your own refill. The pharmacist will hand you the bag and say the usual thing about taking it with food or water, and you will look at the bottle through different eyes. You will wonder about the dose. You will think about the last time anyone checked your GFR. And instead of putting the bag in your pocket and walking to the car, you will ask one question at the counter, a small question, a question the pharmacist has an answer for, and that 10-second exchange will give you one more piece of information that you bring to your next appointment. These moments compound. Each one is small, each one is quiet, but stacked together over months, they change the way the system treats you, because the system responds to patients who ask questions. It always has. The problem is that nobody told you which questions to ask. Now you know. You are no longer the person who takes the pills and moves on with Tuesday. You are the person who reads the whole blood panel. You are the person who knows the difference between a controlled number and a healthy organ. You are the person Doreen became on a Thursday night, sitting at her kitchen table with a magnifying glass, finding a number nobody mentioned. You are the person Graham deserved to have in his life 11 years earlier. Someone who would have looked at the notebook, looked at the blood panel, and said, "Wait, something does not add up. That is not information. That is identity. Information fades by next week. You will forget the milligram numbers. You will forget the name of the Florida study. That is fine. But the instinct to look at the whole panel, to ask one question, to notice when a pattern does not fit, that stays. Identity stays. The person who notices does not stop noticing because a month passed. You will carry this into every appointment, every pharmacy pickup, every conversation about health for the rest of the time you have. And the people around you will be better for it because you will ask the questions they did not know to ask. You earned this by staying for 50 minutes, by listening to Graham's story and not clicking away, by learning what happened in Florida and not telling yourself that could never be me, by watching Doreen walk into a Tuesday appointment and walk out different. Nobody handed you this. You built it, minute by minute, pattern by pattern. It is yours now. Someone is going to ask you, probably soon, whether you should stop taking your blood pressure medication after watching this. The answer is no. Do not stop anything tonight. The thing more dangerous than a medication that strains your kidneys is uncontrolled blood pressure with no medication at all. This is about adding one conversation to your next appointment. Keep taking what you are taking until your doctor, with you in the room, decides something should change. What if your doctor does not think your medication is affecting your kidneys? Some will not. That is fine. You do not need to convince them with an argument. Ask them to order 5 blood tests: GFR, creatinine, BUN, microalbumin, and a full electrolyte panel. Those tests cost less than dinner for 2. When the numbers come back, they do the persuading for you. What if your GFR is already low? Then you are exactly where Doreen was in October. A low GFR does not mean it is over. It means the filter is strained. Strained is not broken. Reducing the strain, adjusting the dose, adding hydration and minerals can stabilize filtration even at stage 3. The goal is not to reverse a decade. The goal is to stop the slide and protect what remains. What about the morning routine Doreen used? 16 ounces of water with a 1/4 teaspoon of magnesium citrate powder taken before her morning pills. The water gives the kidneys volume to work with before the medication starts pulling fluid out. The magnesium replaces what diuretics strip. Check with your doctor before starting magnesium if you have kidney disease, because the dose matters. Can lifestyle changes actually replace blood pressure medication? Some can reduce the dose over time. Morning hydration, magnesium, a Mediterranean eating pattern, and daily walking can lower blood pressure by 8 to 14 points in adults over 60. That is the difference between 3 pills and 1. But no lifestyle change replaces medication without your doctor supervising the shift. Add first, subtract later, together. What if you are on one of the 5 medications and your doctor says it is fine? It might be fine. Dose matters, age matters, kidney function matters. The question is not whether the pill is bad. The question is whether anyone has checked what it is costing your kidneys at your current dose after this many years. If nobody has checked, ask them to. What if this all feels like too much to remember? It is not. You do not need to memorize 5 drug names and 3 mechanisms. You need 1 sheet of paper with 5 test names and 1 question. That is it. GFR, creatinine, BUN, microalbumin, electrolytes. And the question, can we look at whether my blood pressure medication is affecting my kidneys? Write it down now. Put it in your wallet. Bring it to your next visit. The paper does the remembering for you. I want you to do one more thing right now. Take your hand and place it flat on your lower back, just above your hip on either side. Press gently. That is where your kidneys sit. 2 organs the size of your fist, tucked behind everything, working every second you are alive. You have probably never touched them before. Now you know where they are, and you know what they need from you. There is one more thing I want to show you before we finish. It is the reason I spent an hour on this and not 15 minutes. It is the reason every pattern, every story, every name in this hour was building towards something larger than blood pressure. The pattern you just learned, medication optimized for one organ while silently degrading another, is not unique to your blood pressure pills and your kidneys. It is the same pattern running across the entire medical system for adults over 60. Once you see it here, you will see it everywhere. And once you see it everywhere, you will never sit in a doctor's office the same way again. Statins lower cholesterol. They protect the heart. That is the target organ. That is the number on the chart. In some patients over 65, those same statins quietly degrade muscle tissue week by week. The thighs go first, then the calves. The person cannot climb stairs without gripping the railing. Getting out of a low chair requires a hand on the armrest. Getting up from the floor after playing with a grandchild becomes a project. The cholesterol panel looks perfect. The legs do not work the way they did 2 years ago, and the doctor says that is normal for your age. Sound familiar? Proton pump inhibitors reduce acid reflux. They protect the esophagus. Over years, they leach calcium and magnesium from bones, the same minerals the diuretic stripped from Graham's kidneys. The loss is invisible until a fall that should have been a bruise becomes a hip fracture. The stomach feels fine, the bone breaks, and nobody connects the pill the patient swallowed every morning for 6 years to the fracture that happened on a Tuesday afternoon walking to the mailbox. Sleep medications quiet the brain at night. They deliver 8 hours of rest on a sleep tracker. Over months, they dull cognition during the day. The person who used to do the Sunday crossword in pen starts losing words in conversation, starts forgetting where they parked at the grocery store, starts wondering quietly whether this is the beginning of something worse. The sleep score looks great. The mind dims behind it, and the doctor says the sleep is improving. Every one of these follows the exact same architecture you learned today, a medication prescribed for a single outcome, a side effect that damages a different organ over months or years, a monitoring system that watches the target organ obsessively and ignores the collateral damage completely, a patient who does everything right and still declines, and a doctor who says that is normal for your age because the organ they are watching looks fine. You now see this architecture. You did not see it 60 minutes ago. And the reason it matters beyond kidneys is that this way of seeing applies to every prescription bottle on your counter, every single one. The question is always the same. What is this pill optimizing for, and what is it costing somewhere else in my body? No single specialist will ask that question for you. Your cardiologist watches the heart. Your nephrologist watches the kidneys. Your gastroenterologist watches the gut. Your orthopedist watches the bones. Each one sees their organ in high definition and the others in a blur. The chart is organized by specialty. The appointments are scheduled by specialty. The billing is coded by specialty. Nobody in the building is organized around the whole person sitting in the waiting room. You are the only person in every one of those rooms who lives in the whole body. You are the only one who can connect what the cardiologist prescribed to what the nephrologist found to what the orthopedist suspects. You are the one who carries the full picture from room to room. Nobody else does. Nobody else can. That is the bigger pattern this hour gave you. The 5 pills were the door. What is on the other side is a new way of thinking about your body and your medical care, a way that puts you at the center of a system that was never designed to put you there. That is worth more than any single pill name. That is the thing that stays. It is morning again. The counter looks the same. The bottles are still there. The toaster is still warm. The coffee is still cooling while you do something in the other room. But you are not the same person who stood here at the beginning of this hour. You pick up the first bottle. You read the label, not the name, the dose. And for the first time, you do not just see a pill you take before breakfast. You see a choice someone made for your heart that nobody checked against your kidneys. You see a dose that made sense at 58 and might not make sense at 71. You see a conversation waiting to happen at your next appointment, a real one. You set the bottle down. You pick up a glass. You fill it with water, 16 ounces. You drink it before you take anything else. And that small act, water before pills, is the first thing Doreen did. It is the simplest change in this entire hour, and it is yours now. You open a notebook. The one you keep by the salt shaker, or the notes app on your phone, or the napkin your daughter handed you at Sunday dinner, and you write down 5 test names and 1 question. GFR, creatinine, BUN, microalbumin, electrolytes, and then the question, can we look at whether my blood pressure medication is affecting my kidneys? That is all. 5 names, 1 question. 1 sheet of paper between the person you were this morning and the person you are right now. The bottles are not the enemy. They never were. They are tools that someone chose for you at a time when you did not know what questions to ask. Now you do. They are tools, and you are now the person who understands what each one costs, what each one protects, and who to talk to when the balance shifts. You were never the problem. You were just never given the whole picture. Save this video, not for later, for the person in your life who has 5 bottles on their counter and has never been told what you just learned. Send it to them the way Doreen's daughter sent one to her on a Thursday evening, 1 kitchen table at a time. That is how this works.